Hello and welcome to Liberty International's panel on COVID and vaccines. We'll start in a few minutes, but first I just want to welcome all of you, and more are coming in as we speak. I also want to tell you that this is being recorded, and I will be also letting you know that we're streaming to Facebook, at least shortly. And I will give you a little bit more information in just a minute. I'm basically going to let everybody get into the room and then we'll take it from there. And I see people coming in. I see your pictures. It's great. I know some of you have your video off. That's okay too. It's whatever you prefer. So I'm going to give it just another 30 seconds or so, and then we'll get started. And for those who are just coming in now, I want to remind you that we are recording. We will be streaming live to Facebook. And my name is Dr. Mary Ruwart, and I am chair of Liberty International. So I'm going to start now by talking a little bit about myself, and then I'm going to introduce our panelists. So I'm a research scientist by profession. I have a bachelor's in biochem, a PhD in biophysics, postdoctoral work in surgery, and I was in the pharmaceutical industry for about 19 years after I left my assistant professorship of surgery. So I am going to also let you know a little bit about my libertarian background. I have served on the Libertarian National Committee, but I'm best known really for my books, Healing Our World, Short Answers to the Tough Questions, and Death by Regulation, How We Were Robbed of a Golden Age of Health and How We Can Reclaim It. And next, I want to introduce to you Dr. Jeffrey Singer, who is really a very important person. He's been a senior fellow at the Cato Institute, and he is an MD. He is the principal and founder of Valley Surgical Clinics, the largest and oldest group of private surgical practice in Arizona. And he's been in practice as a surgeon for more than 35 years. He's been a visiting fellow at the Goldwater Institute. He's a member of the board of scientific advisors of the American Council on Science and Health. He's a regular contributor to many journals, and I could really go on and on. He's quite well versed in medicine, and he's gotten his BA from Brooklyn College and his MD from New York Medical College. He's a fellow of the American College of Surgeons, which is a very prestigious thing. And next, I want to introduce you to Kyle Varner. He is also on the board of Liberty International, and he is a hospitalist. Most of his patients are COVID patients, so he's obviously very familiar with this disease. And he has recently started getting involved as an investigator in clinical trials, which I'm very interested in because I currently chair an IRB, which are the boards that look at the informed consent that these patients get. And hopefully, of course, we make sure all the things that are important for them to know are in there. So Kyle Varner is an MD, and he is going to be sharing his views with us. And of course, because he works with COVID patients, we'll hear something from the front lines. So next, I just want to give you a little bit of background on the organization that is sponsoring this, Liberty International. You know, we have been around as the International Society for Individual Liberty for over 30 years. And we're currently involved in focusing on spreading the word of liberty throughout the world. We kind of think of ourselves as a Johnny Appleseed, planting the seeds of liberty in different places and helping them grow. Our current focus is on educating new libertarians on the principles of libertarianism. And our latest endeavor in that was to have a 16-week course, a 16-segment course, I should say, over 8 weeks, where Kyle, myself, and some other board members on Liberty International, Dr. Byland and Professor Schoolin, tried to educate people around the world through Zoom on the principles of liberty. Many of you who have been in the movement for a long time know that the advocates for self-government used to do that, but with the retirement of Sharon Harris, that's not happening as much anymore. So we're trying to pick up that, or fill that vacuum, I should say, that's been left. So if you have any questions during this presentation, you can put them in the chat box, and that way we will be able to get them answered. If you're listening on Facebook, the place to put them is just right under the post. Ask the questions right there on Facebook. And you can, if you want to, try, if that nothing works and you're getting desperate, you could try to email me, mary@ruwart.com, MARY@RUWART.com. And next, I'm going to go ahead and get us started, and I'm sure we'll have a lot of questions, we'll have a lot of discussion, but I want to start by asking both of our panelists to take about 5 minutes and really talk about their perspective on COVID and the vaccines. And I know that a lot of the people attending here might be interested in hearing comments on autism, Bill Gates and his foundation, which promotes vaccines, the kind of trust or lack thereof that the American people might have in the vaccines, and maybe talk about the vaccine technology, which is really new and exciting, and hopefully will be very relevant and helpful, not just with the COVID vaccine, but in the future. So Jeffrey, would you like to start?
Sure. Well, thank you very much for having me here. First of all, I think we're 10 months into the pandemic right now. So we know a lot more about COVID-19 than we did when this all began, which was around February, March for most of the world. So what we do know is, fortunately, is not nearly as deadly as we originally feared. It seems to be, something like 80% of all deaths are over the age of 65 and 95% are over the age of 50. So it's skewed towards the older populations and people with pre-existing vulnerabilities, comorbidities. It's actually, for those people, it's a lot more dangerous than the flu. For people who are young, it's less dangerous than the flu, particularly the very young. Another thing we've learned over time is we originally didn't know, for example, whether you can develop any immunity to it, but now we have a lot of evidence that people who've been exposed to COVID-19 have developed antibodies to it that seem to persist at least 6 or 7 months later. There have been several good quality studies showing robust antibody levels 6 or 7 months later. That's a good thing. We know a significant proportion of people who get COVID-19 infections are either asymptomatic or very mildly symptomatic. That's a good thing. Now, let's do some bad things. A lot of the initial measures to control the pandemic, when we knew less about it, to me, it's certainly more understandable and excusable when we thought this could possibly be much more deadly and more like the Spanish flu. They initially were designed at, number one, making sure our healthcare systems don't get overwhelmed. Because if they get overwhelmed, not only will we not be able to take care of the COVID patients, but we'll not be able to take care of anyone else. So that was the initial goal. And initially, to accomplish that, a lot of governors in our country, different countries have different ways of dealing with this. I know this is an international meeting. In the United States, we have a federal system, so governors of states are given much more authority on how to handle public health emergencies, and some states more than others shut down most of society. We've learned over time that a lot of those lockdowns, by the time the lockdowns were implemented, in many cases just through voluntary activity by the general public, people were already engaged in social distancing and practicing behavioral changes to mitigate the spread. Open Table, which is an online restaurant reservation website, had reported a dramatic drop-off in restaurant reservations in March. So we've also learned that a lot of the pandemic policies by governments, they involve trade-offs that initially I think a lot of our policy makers weren't taking enough into consideration. So that, for example, when you shut down economic activity, there are some segments of society that can weather that better than others. People who have work that they can continue to do remotely, but there are other people whose livelihoods are being destroyed. Young children are missing out on crucial milestones in their cognitive and social development when schools are moved to remote only, particularly for very young children. There's people who have other medical needs, are having either non-emergency medical needs go unattended, which will have long-term consequences. We're seeing increased cases of depression and suicide and substance use disorder exacerbated by isolation. So there are a lot of public health, in my opinion, it involves more than taking care of one disease. It's public health in general. So a lot of our policy makers focused almost exclusively on the virus without weighing the other trade-offs involved. And so as we've learned more about this, I would argue that we should have a much more nuanced and targeted approach to controlling the virus. This virus is going to be part of the environment. There's only one virus that affects humans, to my knowledge, that's ever been eradicated, and that's the smallpox virus, which is now in a laboratory. And, and that took a couple hundred years to eradicate. So the notion that we could eradicate this virus is unrealistic. Eventually, this virus will develop, we will develop either what's known as herd immunity, where enough people have immunity that there are enough roadblocks to the virus rapidly spreading throughout society. But it will always be here. There'll always be occasional outbreaks here and there, but hopefully it will become something that we've learned to just adapt to and live with it in our world, like we live with flu seasons and other things like that. The quickest way to get there, of course, is through getting a vaccine, because there's two ways you can get immune to this virus: either catch it, which might kill you, or get vaccinated. So now, and we're probably going to reach there now that we see the advent of vaccines, between people who have gotten it already or are getting it and the people who will be getting vaccinated. I think that brings us closer to the finish line. The finish line being when we reach a point where this virus is no longer a major disruptor and it's just sort of something that we learn to live with in our environment and doesn't affect enough people to disrupt society. I'm very excited about the vaccines coming online. Particularly, I think some other lessons we've learned from this is that governments failed. There's a legit, unless you're an anarchist, libertarians would believe that there is a legitimate role to play in a public health emergency, just like in war. There is a legitimate role for the government to play, but it's largely to provide good, reliable information on what's going on and how to defend yourself against it, and to provide infrastructure. Instead, our government was giving us mixed signals from the beginning on how, whether or not this was a pandemic, how severe it was. It was telling us, you wear a mask, don't wear a mask, then wear a mask, giving us all sorts of, they even admit they were so-called noble lies, that they were intentionally not telling us the truth, because if it was for our own good, which doesn't, of course, create trust in the government institutions. And then the regulatory apparatus was largely responsible for just an inexcusable delay in getting tests out there, which are necessary if we're going to learn where we stand with this virus and how to get the infected people away from the non-infected people. And we've learned with the rapidity through which a vaccine has been developed, how, gee, if the government wanted to, it could streamline its regulatory apparatus dramatically. You could do something that normally takes 10 years in less than a year if you want to get some of the burdensome regulations out of the way. So there are a lot of lessons to learn going forward. And when this is over with, I think we should take stock. We need to do dramatic regulatory reform, and the government needs to get a lot better at being honest with us and giving us good information that we can use, and finally allow as many of the mitigation to be, as much of the mitigation as possible to be done at the local level by people with using local knowledge who could have more flexibility to make adjustments based upon changes in real time where they are.
Yeah, well, thank you, Jeffrey. Really appreciate that summary. Kyle, why don't you go ahead and tell us in that 5-minute slot what you think?
So, you know, a year ago right now, I was enjoying the lead up to Christmas in Colombia. And I never imagined that that a year later, I'd be in the situation I'm in. I'm a hospitalist. So I guess I would preface everything I'm about to say by just noting that I have a biased sample. And what I mean by that is that if you get COVID-19 and you do well, you don't ever come to my attention. You come to my attention if you get COVID-19 and you do poorly. So my sample size in my brain, the whole sample of COVID patients I see, are all the disasters. And a day, it's not a day that goes by that I don't become more alarmed and in many ways kind of more despondent about the way society has been addressing this, because I see the people dying. I'm the one who has to pick up the phone and call and tell their families that they've died. I've had, you know, husband and wife together in the hospital die together. It's been in a lot of ways kind of soul crushing. And then I get on social media and I hear people talking about a 99.9% survival rate, and I hear them saying things like, well, you know, this just affects the elderly, and to me that sounds very much like they're devaluing the lives of my patients, and so it's a difficult situation. But I've never in my life seen something like this, and seen the changes in that we've had to make in the hospital. You know, we're not in a situation where the patients are piling up in the hallways, right? We haven't run out of ventilators per se, but we have changed the way we practice medicine so that there are patients on a medical floor now who a year ago would have been in the ICU. But we've just little by little, as the resource constraints have forced us, we've changed how we practice medicine so that we can still accommodate everybody who needs care. But obviously not everybody's getting care because non-urgent procedures are canceled now because we can't take the risk that our procedure is going to put somebody in the hospital and take a bed. So we're in a difficult situation. 300,000 Americans have lost their lives. More than 1.5 million people around the world have lost their lives. This is more severe than many wars. This is horrible, horrible time we're in. So I'm really relieved and excited that the vaccine is here. I will be getting it hopefully in the next few days. And generally, my orientation to vaccines is that this is amazing because it's just something you can, an injection you can get, and you can prevent yourself from getting a really terrible disease. And then when vaccine campaigns are really effective, vaccines become unpopular because people forget and they don't realize the benefits of everybody getting these vaccines. And I have done a lot of work in Colombia on the Venezuelan border, where I've seen the results of widespread lack of vaccinations. That's the first time I saw a case of measles. The first time I saw a case of mumps, it was actually mumps encephalitis or mumps of the brain. I saw that in a refugee who had come to the United States. And so I have a really positive view of this very easy thing you can do to prevent these really bad diseases. So that's where I look at vaccines. I'm really excited about the technology used by Moderna and by Pfizer to create the mRNA vaccine, because this is technology that is going to open the door to better vaccines in the future, but also to more vaccines against more diseases, including perhaps a universal influenza vaccine, meaning potentially we're talking about in a decade, there not being such a thing as flu season. We're talking about an HIV vaccine, maybe vaccines for some of these more difficult and rare diseases are rare for us, like dengue, or maybe we can get a malaria vaccine or a leptospirosis vaccine. That's more speculative because those are different mechanisms of infection. But I think there's a huge potential for mRNA therapeutics. They're working right now on personalized cancer vaccines based on the same technology. So I've got a lot of hope, and I've got a lot of hope that over the coming months, we're going to see big change because, initially vaccination is going to be limited, but it's directed at the highest risk, which means that we're going to hopefully see the results of that very quickly in fewer hospitalizations, and for me, getting more back to normal, where I'm dealing with things like chest pain and regular bacterial pneumonia and cancer and liver disease. That's what I signed up for, right? I didn't necessarily sign. I mean, I signed up for this, though, but I can't wait to get back to what my job used to be, and be doing some of those more mundane things. So, I agree with a lot of what Jeff said about the difficulties associated with government-imposed lockdowns, because when you're in a pandemic situation, right, you have, on the one hand, heightened risk of everything you do, risk yourself and risk to others, and then you have costs associated with the things you do. If you don't go to work, there are costs, but there are benefits, right? And government's a really blunt instrument to try to make that cost-benefit calculation. They make errors because they don't pay the costs, they don't receive the benefits, and so they don't have the information. Whereas when individuals make those, there's a much better situation. But I think, unfortunately, we have a problem with reality in our society, an epistemological illness, if you will. And a large portion of our society has taken it as a mark of their political identity to scoff at the virus and to say, I don't want to wear a mask, I don't want to, and they deny it, and they spread lies and conspiracies. And so we've got a large segment of our population who's not approaching the virus as, okay, this is a serious threat, and I have to make cost and benefit analyses in the way that's the way we need to do. We need to make cost and benefit analyses as individuals. But then we got all these people out there who say it's a hoax and all kinds of crazy things. If you just get on Facebook, you know all the crazy things that people are saying. And so the result is we've got a lot of people out there doing incredibly stupid things that put other people at risk. And that's why we are in the United States. We're the COVID hotspot of the world. I mean, if you want to look at New Zealand, Australia, Iceland, the Cayman Islands, I mean, these are countries practically untouched. And now that the vaccine is here, these countries are going to get away, in some cases, like New Zealand, they're going to get away with maybe 25 to 30 deaths total. That's amazing. And there are a lot of people in the U.S. who are dying over 3,000 a day. And I don't think that has a lot to do with the government. I think that has a lot to do with the relationship of the average person in that country to reality. We have to accept reality and then act accordingly. And so at the end of the day, I'm just really saddened and kind of despondent over the whole way our country, as an American, that we've responded. I think it's been really unfortunate.
Kyle, Jeffrey has a question for you.
I want
take it.
Yeah, I want this. Well, now you maybe want to say something else as well. But at first, I was going to say I wanted your thoughts on this, Kyle. You know, there's a lot of this debate among healthcare practitioners about what's the best type of preventative medicine. You know, what are the best things you can. It's my opinion that there are just a few things that are proven to be effective for preventative healthcare. You know, not smoking is a good one, for example. Keeping yourself in good health, in good weight, rather. You know, you're keeping your weight fit. But vaccinations, immunizations is probably one of the most significant breakthroughs in preventative medicine in human history, and probably one of the best things you could do to immune, and sanitation, of course, another one. But it's one of the best things you can do to prolong your life. And I just kind of wanted to, is that what you would say as well? Among, you know, we could argue about some other, what's good preventive medicine, what's not, but on the vaccinations, I mean, that's an obvious one.
To me, vaccinations are a no-brainer. I mean, I'm vaccinated for nearly everything under the sun because I travel so much. But yeah, vaccinations are a no-brainer, depending on, again, what your risk level is, right? If you're going to sit in the United States, you don't need a yellow fever vaccine. But there are these diseases that can cut short your life. I mean, if you just look at the increase in life expectancy over time, yeah, a large amount of that was driven by decreases in infant mortality. But keep in mind, infant and child mortality are probably some of the mortality, the age groups where vaccines have done the most good. But yeah, we live longer thanks to vaccines. They're wonderful. And anti-vaxxerism can only thrive in a world where vaccines have been successful.
But one other area I want to differ with you is when you use the example of Iceland and New Zealand and Cayman Islands. If you notice, they're all islands. So a couple of things I think you can much more easily control something when you're isolated by water and you could kind of put like almost a bubble over yourself, which they've done in those places.
Yeah.
I don't think a 330 million heterogeneous country like ours, where we have a federal system as well, where we have 50 different states with 50 different policies. I don't think it's realistic to even think you could do that. That's number one. Number two is I think a lot of the reasons why we're seeing, some people, I agree with you, are actually flouting recommendations, like they're doing the opposite of what a person should do, just out of consideration for your neighbors. It's almost like they're not concerned about the externality that they're putting on their neighbors. But part of that, I blame the fact that early in the game, many of our governors and our other policymakers, between not being truthful with everybody and having policies that were one size fits all. Like, for example, in my state of Arizona, we locked down completely in April when there was nothing going on here. And then we released the lockdown, and in June, everything came. And at that point, people were not getting ready to go, not willing to go through another lockdown. So a lot of the early mistakes, I think, have made people more resistant to doing some simple things because they don't trust anybody anymore. And then there's also, when you have policymakers say things like, don't go to a restaurant, and then go to a restaurant, get caught on video going to a restaurant. Or when you say things like, we're going to close outdoor dining, even though there's no evidence that outdoor dining does anything. If you want people to cooperate, what you're asking them to do has got to make some sense and has got to have some evidence backing it up. So that's also a factor here, because I agree with you. There are a lot of people I see around who is almost like intentionally not being considerate. And it's not a big sacrifice, to wear a mask when you go into a public place, even if you don't personally believe that masks make a difference. If it makes your neighbors feel safer, be neighborly. But some people are intentionally being contrary because of the way they were mistreated earlier.
Yeah, I think you're absolutely right. There's something to be said here for hypocrisy and inefficient and bad decision making at a state level that has driven some of this. But I think that's only some of it. And I think that we're a very factional society now, unfortunately. And the role of politics in our society is so huge, and the factionalism is so huge, that if the governor's a Democrat and he says you should wear a mask, most of the Republicans immediately don't want to wear masks.
I agree.
And that's really unfortunate, because the governor shouldn't matter, right? And that really goes to show how much harm that politics has done to the fabric of our society, where now people live in separate realities based on their political orientations, and they are willing to believe something that's false because their preferred faction believes it. And that, I believe that it is that kind of factionalism and choose your own version of reality that people are living in, that's led to our civil society being unable to respond. And that same kind of choose your own reality is, I think, what's going to drive opposition to vaccines, and is potentially going to really shackle the good that the rollout of this vaccine could do.
Well, and how about the idea that I hear libertarians saying, that vaccine should not be mandated because it should be an individual choice. But I've also heard libertarians say, some, that it's, you should get a vaccine, because if you don't and you give somebody COVID, then you should be liable. So what do you two think about that concept? Is libertarianism supporting private choice, or is libertarianism supporting the idea that we need to protect our neighbor?
If I may, actually, I wrote about this topic a couple of times. Reason Magazine a few years ago had a symposium on this topic, and people could look it up. I personally don't believe that you have a right to force someone to get vaccinated, but I do know that there is a difference of opinion among libertarians. That's one of those areas where libertarians can get into arguments. And some of the people in that symposium believe that if you have COVID-19, let's say, then you're basically threatened. It's violation of the non-aggression principle to refuse to vaccinate yourself and therefore threaten your fellow neighbors. So, and I can understand the argument. I have problems with it for on a number of levels, which is number one, you don't know if that person is going to be asymptomatic when they get it. You don't know if you have it. If you get vaccinated, it may not make you immune, but you may have a complication from getting that vaccine. What happens if you get vaccinated and not only did it not give you immunity, but you had a terrible anaphylactic reaction to the vaccine? So then who's the victim of aggression here? So I personally believe that you do not have a right to violate the rights of another person by injecting something into them against their will. On the other hand, if a person becomes infected with something that could kill or seriously injure their neighbors, I think you do have a right, and this is where some libertarians may disagree with me, I think you do have a right to have that person quarantined as an act of basically defense against that person then becoming it, because now that person is going to be, intentionally or not, an aggressor. So that's my position: is you have a right to quarantine people, but you have no right to force people to become vaccinated.
Okay, Kyle,
I think,
did you want to
yeah,
chime in?
so I think if you come to libertarianism, and people come to libertarianism for all kinds of backgrounds, but if you come from a natural rights perspective, I don't think there's an easy answer about from a philosophical standpoint about mandatory vaccines. And what I mean by that is there's a strong case to be made that if you appear in public unvaccinated, you're an unmitigated risk to those around you unless you're freeloading off of herd immunity. That being said, I don't believe it's wise to require vaccines. And I would just refer to the current situation. And I would give some practical reasons why vaccination should be mandatory. Should be voluntary. And the first is that there are a bunch of people who want this vaccine and there aren't enough vaccines out there. Why in the world would you force someone to get it when there are people behind them in line saying, me, I want it? If you don't want it, get out of line. Go somewhere else and let the people who want it get it. The second reason is because the anti-vaxxer movement is, they're a loud movement. They're somewhat powerful. But the problem is they're also, they're dishonest. If you force an anti-vaxxer to get a vaccine, they will then proceed to lie about the supposed consequences of the vaccine. And the result is going to be the spreading of mistrust against the vaccine. Now, these people will lie no matter what. But I would rather they don't get the vaccine and thereby don't have the standing to go before the media and say this vaccine hurt me. But you're only going to get these people lying about being hurt by the vaccine if they're forced to get the vaccine.
Right.
So you could see a situation where by forcing people to get the vaccine, fewer people overall end up getting it. I don't want that. And the third thing I would say is there's a big difference between the government mandating a vaccine and the market or society deciding that it is de facto mandatory. Airlines are going to require vaccines for people to fly. That's pretty clear. If you don't, eventually it's going to be, if you don't show us your proof of vaccination, you don't fly. And that's based on the business interests of the airline. Concerts are going to require proof of vaccination to attend concerts or some kind of proof of immunity. And that's for the business interests of the concert goers, because at the end of the day, people don't want to get infected. They don't want to spread infection, and they're going to behave that way. And that's the free market working.
And those are voluntary transactions. Those are voluntary.
Exactly, but it's the same way, if you tattoo a swastika on your forehead and then you try to go around applying for jobs, you're going to have a bad time. That's not censorship, right? And so it's the same way. It's society saying we put certain limits on other people, not through the government, but through the individual choices that add up to a de facto mandate or a de facto prohibition. Here in the United States, there's a de facto prohibition on displaying Nazi paraphernalia, not because the government prohibits it, but because society prohibits it through a decentralized, voluntary network of decisions that individuals make. And that's going to be what happens with the vaccine. People are going to voluntarily make the decision to restrict who they associate with. And that is perfectly libertarian. In fact, when we argue for free speech, when we argue against mandates, we always argue that society has a mechanism for dealing with the truly odious or the truly harmful. And I think we need to stand behind that. So I think it's very bad indeed for libertarians to start criticizing the voluntary market actions that really actually do take the place. I used to say this about masks. They say, oh, don't mask shame me. I don't want to wear a mask. Well, actually, mask shaming is the free market answer to mask mandates. If you just want to walk around with no mask, you're just immature. If you want to talk about masks versus no masks, talk about mask mandates versus no mandates, the real question is society strong enough to step in and supplant the role of the state? Is society strong enough where people behave responsibly and urge their fellow humans to behave responsibly without the coercive hand of the state? And if the answer to that is yes, then we have a society that's mature enough and responsible enough for liberty. And if the answer to that is no, we're in trouble.
Yeah, shaming is the way civil society regulates itself. I received a question from Walter Smith regarding my discussion on not having vaccines been mandatory. He said, how would you address the asymptomatic carriers? Well, to me, if you know they're a carrier, which means you tested them and they're positive, I would address an asymptomatic carrier the same way I would address a symptomatic carrier, which is you can infect me, even though there's a lot of evidence suggesting asymptomatic carriers are less likely to be contagious, but they still can be contagious. So I would say you don't have to get vaccinated, but you're carrier, so you got to be isolated for, let's say, 7 to 10 days to protect me from your aggression. That's how it. Now, on the other hand, if you're saying, how do you know a person who never got tested isn't an asymptomatic carrier? Well, I can't just go randomly assume something that's proving a negative. And so to force that person to get vaccinated when I don't even know if they're a carrier and possibly have them get a fatal or life-threatening complication of the vaccination, let's say an anaphylactic reaction, then I'm the aggressor again. So to me, that if you're a carrier, if you're diagnosed with having the disease, regardless of your degree of symptoms, whether from mild to severe, you now need to be quarantined until you're no longer contagious. I have no problem with that from a libertarian standpoint. I do have a problem with taking somebody and forcing something into their body that they refuse to have forced into their body. And then, like Kyle said, I also have a right to say, I don't want to associate with you unless you get vaccinated. Now they could say, fine, then I guess we're done. That's the way people work in a free society.
Well, of course, now we're finding that the PCR test has a lot of false positives. What they do with the PCR test, for those of you who aren't familiar with it, is we don't have the technology really to detect like a few virus particles in your nose. So when they take a swab, they have to do what's called amplification. I guess you could think about it, this isn't exactly what happens, but you can think about it as they kind of grow this stuff up in a test tube. And if they do it about 30 times of amplification, the tests, generally speaking, appear to be quite accurate. But if they go beyond that, and many of the testing has gone beyond that, then there are a lot of false positives. If you get a false positive, if you get a positive between that 30 and 40 amplification cycle, the current level of knowledge suggests that there's only about a 20% chance that that positive is accurate. So given that we don't know how big this factor is in the general public, and given that we don't really have, we have probably a better test for like antibodies than we would for detecting somebody who has gone through the PCR test, and we don't know how many amplifications they have. It gets very difficult to decide who actually has COVID and who is an asymptomatic carrier. So, again, getting back to this libertarian question, if we quarantine somebody who has a positive PCR test, for example, and it turns out that they never did have COVID, then we are kind of aggressing against them. So it's a very difficult balancing act, I think, in order to decide when we do that and when we don't, or if we do that.
Yeah,
Although I would say, we can't be omniscient, right? So I know COVID's going around. You got tested, you tested positive. Well, it's possible that it's a false positive. It's not likely that it's a false positive. And I just, I just think that it's not a violation, non-aggressive principle to acting on the results of that, unless I'm given more information that it's multiple, more than 30 cycles, in which case I could say, you got to get you got to get the test again before I decide if we're going to quarantine you. But you can't, you can't be omniscient.
Mhm.
Yeah, I want to caution against the misinterpretation of the rise in false positives as the cycles go up, because I think some of this information is being amplified by people who have an interest in denying that the virus is as big of a problem as it is. There are people out there who want to say that there are way fewer deaths than there actually are, that it's not as widespread as it actually is, and they're amplifying this. But here's what it comes down to. When you design a test like this, where you got to choose amplification cycles, you're choosing between higher numbers of false positives or higher numbers of false negatives. You don't, there's not really a way to have your cake and eat it too. When you have to choose the number of amplification cycles, the more amplification cycles you do, the fewer false negatives, but the more false positives you will have. That's just the nature of the test. So what are these tests being designed for? Well, primarily, they're being designed for the evaluation of people with symptoms. And so if you have symptoms, you want to minimize the number of false negatives, because a false negative can lead to exposure of somebody who's of the healthcare workers or other people to somebody who actually has it. It can lead to delayed treatment. It can lead to additional testing for other things. So there are a lot of problems with false negatives. And the problems with false positives really are, you have to go into isolation and retest. So that's why the people are making the decision to have higher numbers of amplification cycles. But I think it's also important that we always understand that there's no laboratory study on Earth that can be interpreted on its own. You can't just say, this test is 80% accurate, 90% accurate. You have to interpret them in the setting of something called Bayes' theorem, which suggests that the pretest probability, or the likelihood you are to have the disease before you even get tested, affects the post-test probability, the positive or negative predictive value of the test. So if you're testing somebody with symptoms, false positives cease to really be a meaningful consideration. And if you're testing asymptomatic people, then you need to be confirming your positive tests. So that would be my takeaway from that.
Yeah, and it's a very complex subject, and that's what we're kind of bringing out here. There's a lot we don't know, and that really goes to another aspect of this. I recently read a paper that a very large group of Italian blood samples from September 2019 were tested for the COVID antibodies, which should be a pretty good predictor of whether these people had infection or not. And it turned out that 11% of the Italian population that they surveyed had antibodies, which suggests, of course, that at least in Italy, COVID's been around for quite a while, because this is way before. To get 11%, you've already got a lot of exposure. The studies I've seen in the US have been smaller, and the numbers have also been smaller. But I'd like to ask the panelists if they have further data on this, or if they have any explanation why the Italians would be higher than the US, or if they have any other gems of wisdom to share with the audience.
Jeff?
Well, I'm familiar with that study, and it may turn out that this virus was actually making its inroads into the planet earlier than we thought. I mean, the Chinese first said, I think, that it appeared in December, then they revised that up to November. So maybe it was as early as September, with all the world travel going on. It's possible that it just hadn't blossomed yet, but it was already starting to get around earlier than we realized, and it started to really hit full steam in most of the world around February. That's when it really started to take off. So that's my take on it.
Mm-hmm. Yeah, I guess my take is a little different. I don't think that it's likely that there was any meaningful amount of spread prior to when we noticed the spread. And the simple fact is that these are memorable patients. And prior to the pandemic really being defined, somebody who presented like a COVID-19 patient in the ER will just leave this kind of searing memory in the minds of everybody who took care of them. And so if you just, and this is just me talking to people, I talk to critical care docs all over the United States who are friends of mine, colleagues of mine, all this stuff. They said, well, yeah, I've got a few I think might have had COVID-19 before the pandemic, but one here, one there. There was no stress on the ICUs. There were not a bunch of these, right? If 3 or 4 people show up in one hospital with a COVID-like illness in December 2019, people would have been calling all their health departments, the CDC, and sounding the alarm because it was so it's so shocking. And if 3 or 4 showed up at once, you would have said something is going on. So I don't think, I mean, Italy is a place where they had their first outbreak and they had it prior to understanding what was going on, and it really spread and killed a lot of people. So I think it's reasonable to think that a large number of Italians were, I mean, we know a large number of Italians, especially in Northern Italy, were infected. As another data point, about 830 people in per 100,000 population in my city have tested positive for COVID-19 in the last 2 weeks. So, if we kind of use like back of the envelope map and think we're catching like 1 out of 4 of the infections, we're looking at about 1% of the population being infected in a given week. So I mean, it's after 10 months of a disease that has, and right now we're in the middle of a surge here, but after 10 months of a disease that has the potential to surge like that, it makes sense to me that we could have 10, 20%. So that's how I look at it. It doesn't surprise me.
And it could be that we do have a lot of asymptomatic carriers, and that a lot of this 11% were asymptomatic or had something mild and never went to the hospital as well. And except for those few cases that you're talking about that might have, created some concern.
And the hospitals were getting overwhelmed, then it was really, really widespread in the community.
Yeah. Yes.
So in many ways, I wonder if we shouldn't be looking, if we shouldn't try to be really kind of looking backwards, or just start with the hospitalizations and then extrapolate out to the community rather than just trying to go out and test and then kind of extrapolate onto the hospital. I wonder if that's going to be a better marker at the end of the day, at the end of this, when we start looking at all the data and it's all over, if that's not going to be a better marker of disease prevalence than the number of positive tests is the number of hospitalizations.
Yeah, I think what's going to happen is as we learn more about this, we'll be able to model it and see if our model matches the predictions. And we aren't there yet, though. And we did get a question I see in the chat from Walter Smith. Does a study, the one I was just talking about, address the possibility of viral mutation? And I do not know the answer to that question. I don't know what the specificity of the antibodies the antibody test that was used in that. I haven't studied that, but maybe one of the panelists do.
Well, the study that from Italy, I don't think did, but there was a recent study just out of the UK that suggests new strains are developing, which brings us back to the vaccine, because this I think is important. This is one of the reasons I'm so excited about the new mRNA vaccine, because for those who are unfamiliar with this, the conventional way of making vaccines has usually been to either inject a live or a dead or a modified or attenuated virus into someone. And of course, that always carries the risk that the person can catch that virus. What the RNA technology is, scientists have been discussing this since the 70s. They've been wanting to do this. So the genome that has been distributed to the world, the genome for the COVID-19 virus, which is also used to design the PCR tests. So at both Moderna and Pfizer, they synthesized a strand of RNA to decode the portion of the genome that makes the protein spike on the coronavirus surface that the coronavirus uses to invade cells of the host. And so you're injected with mRNA, you're not injected with a virus. The mRNA goes into the outer cytoplasm of the cell, which is the part outside the nucleus. It's not able to get into the nucleus. And in the cytoplasm, it gets the cell to produce these protein spikes. And these protein spikes are sort of universal for the coronavirus. So it doesn't, first of all, these protein spikes are next extruded out into your bloodstream, where they invite your B cells to make antibodies to them, but they're also on the surface of the host cell before they're extruded out. So they stimulate a T cell response, which is responsible for a lot of the lasting immunity and the memory. The standard vaccines that just inject live or attenuated virus into people don't you usually invoke a T cell response, just the antibody response. So that this may have lasting immunity. But the thing is that even if the virus strain changes, whatever strain that's going to be is going to have that protein spike on it, because that's how it's going to invade the host cell. So what's exciting about this RNA vaccine is that it should be it should be more impervious to mutations of the COVID virus, more unaffected by it, regardless of how many strains develop. And all viruses mutate. And there are already several documented strains in existence, and we can expect there'll be others. But it doesn't matter, because they're all going to have that protein spike if they're going to work as coronaviruses, and you'll be immune against them. So that's the beauty of. That's why one of the exciting things about this new vaccine. It's you're not being injected with an organism that could infect you, and it doesn't invade your nucleus and modify your DNA like rumors on the internet have been saying. And the immunity that it produces in you involves T cells as well as B cells, which means it's much more likely to be long lasting. And finally, it should be less affected to any mutations the virus may have to become different strains. So this is really what's not to like.
Well, we've gotten another question, by the way, for our panelists. Is there a correlation between extreme sickness from the virus and blood type?
Yeah, so I looked at this, and it looks like maybe there is, and specifically it looks like the Rh antigen. So you know how you got A, B, and then positive or negative. That's the Rh antigen. So it looks like that the absence of the Rh antigen, so negative. If you're a negative, it looks like that does correlate with a lower chance of extreme sickness and a lower chance of mortality. I can't even begin to offer you a theory about why. Number one, because it just doesn't make sense to me from everything I know about the pathophysiology of the disease. So what I would say is correlation does not equal causation. And it may be, for example, that what we're actually observing is that blood groups are more prevalent among certain ethnic groups, and they may be having they may be having, for example, higher rates of obesity or higher rates of diabetes, as we know certain ethnic groups in the US do, and therefore worse outcomes. Because we know that by ethnicity, actually, minority groups are having worse outcomes. And that's because of social determinants of health, we think, because of like a lack of health access and poverty-driven issues. So I think, this is all speculation, but I think maybe that those studies that are coming out looking at blood type are actually serving as a proxy for ethnic and thereby for socioeconomic factors. That's the best explanation I can give you for that.
And, as time goes on, we'll learn more, and there's, we know that comorbidities, of course, are problematic in this disease, but we also know that there are some things that go the opposite way. For example, it seems that people who have high vitamin D levels do much better when they get the disease. They have better outcomes than those that don't. So there are things that one can do to maybe make it so that you are going to survive this if you get it, and that's one of them. I've also seen information suggesting that melatonin doses can help prevent the virus from getting into your cell and replicating. And there's a few other things that I've come across that people believe might be helpful. I would say that if you are a person who has these comorbidities, the best thing you can do to help yourself against having a very severe case of COVID is, of course, lose weight, keep your blood pressure down, and if you are diabetic, try very hard not to aggravate that by having large amounts of sugar. So those are other things maybe to think about.
May I make a comment about the vitamin D bit?
Yes, please.
Okay, so vitamin D has been looked at in medicine for the better part of 2 decades because people started to notice that you had higher all-cause mortality among people with low vitamin D. You had higher heart attacks, more cancer with low vitamin D. And so the natural inclination of everybody was, well, let's start supplementing vitamin D. And unfortunately, what we learned over that process was that supplementing vitamin D did not affect the all-cause mortality. It did not affect the heart attacks. It did not affect the cancer. And so we had to stop asking, wait a minute, what's happening with vitamin D? And what the most common theory is, what I believe is that low vitamin D levels are a marker for overall metabolic health. And one of the biggest things is that vitamin D is a fat-soluble vitamin. So if you're obese, the vitamin D you intake is going to be distributed over a much larger volume. And obesity, we know is associated with these things. So my argument, I'm not going to tell anybody don't take supplemental vitamin D. If you want to take it, if it's low and you want to supplement it, that's fine. But what I would argue is you should ask yourself, why am I low in vitamin D? And you should try to fix those causes. And then you're much more likely to be doing yourself a favor. So try to eat a diet with more fruits and vegetables and foods high in vitamin D, get more exercise, lose weight. These things will help you a lot more than taking supplemental vitamin D. That's my spiel about vitamin D.
I agree.
And actually, there's other evidence too, Kyle, that goes along with that vitamin D that is made naturally when you go out in the sunlight is more potent for reasons we don't understand than supplemented. So your advice is very good, and getting out and getting some sun might be a good thing too. Not too much, obviously, but
actually maybe one of the better things. They found in the swine flu pandemic that people treated outside had lower mortality than people treated indoors. And we're now finding that your levels of nitric oxide go up when you're exposed to the sun. Nitric oxide dilates a little bit the pulmonary artery, and it increases your pulmonary function. And there's actually a device of like artificial light that's designed to produce nitric oxide that is being trialed as a potential treatment for COVID-related respiratory failure, interestingly enough. So a lot of good reasons. The sun is your friend. And if you're afraid of skin cancer, the sun is your friend early in the morning and late in the evening, and try to avoid it around midday because that's when the radiation that causes skin cancer is highest. But the beneficial radiation is pretty much the same all throughout the time the sun is out.
yes. And we did get some other questions too. By the way, if you have a question, go to the chat box and put it in. I saw some people trying to activate their audio, but we're not letting that happen here. We're asking you to put it in the chat box. That way I can read it and give it to the to the panelists or answer it if it's appropriate. So some of the other questions we've gotten is, do you need the vaccine in a given year if you've already had the virus? My supposition is that we probably don't know a good answer to that, but you panelists may wish to say more.
Let me just go first on this one. I actually I got an appointment to get vaccinated this Sunday. There's a 2-dose, so I get the first dose on Sunday, the second dose 3 Sundays from this Sunday. It's already set up. I tested positive for the antibody in May. I don't recall having any symptoms, so I'm one of these asymptomatic cases, but I'm still getting it now. So I'm just talking about my own personal judgment here. Like you said, Mary, we don't know a lot yet. We're still learning. There is a lot of evidence that that antibodies are persisting in robust levels in people 6 months after an infection. But there's also evidence that you have lower antibody levels when you're asymptomatic or mildly symptomatic than you do when you're seriously symptomatic. Mm-hmm. We do know that it doesn't hurt for me to get, even though I have the antibodies, there's nothing wrong with me getting sort of a boost to my immune system and getting vaccinated. So what I've decided to do is, it's been, like I say, 7 months. So I signed up for it. On the other hand, if there's a limited supply, I'm going to let the reason I got to sign up is because I'm a healthcare provider, and so we're given priority. But I would let other healthcare providers who haven't gotten the antibodies go ahead of me in line, because I feel that, you know, I'm less at risk most likely than they are. So, you know, you go ahead and get your vac. Then so fortunately there's enough to go around. So that's why they're letting me come in on Sunday. But, and I told them that I've already had the antibodies. So based upon my priority status, I'm still able to come in and get it.
And I would think the antibody test is much more accurate than the PCR. I mean, more believable, shall we say, probably less false positives.
Yeah. In fact, they tested all the medical staff back in May, and only 2% of the medical staff tested positive. And they use the
Okay.
Abbott Labs Architect platform, which my understanding is you're much more likely to get a false negative than a false positive, because their
Mhm.
control is hospitalized COVID patients, which produce generally higher antibody levels than
Mhm.
asymptomatic or mildly symptomatic people. So it's probably accurate, but either way, I'm just to let people know I have the antibodies and I'm happy to get vaccinated again, despite that.
Sure.
So I've had multiple antibody tests that are negative, and multiple tests for coronavirus that were negative. I can pretty definitively say I have not had coronavirus. And so I'm going to get vaccinated in a couple of days. So I guess you'd say if I were in Jeff's situation where I had antibodies but no recollection of symptoms, I'd probably go ahead and get the vaccine right away. If I had symptoms and a positive PCR and positive antibodies, I was sure I had COVID, then I'd probably say I'm going to wait and let other people get it ahead of me as an altruistic gesture, because I would feel pretty confident in my being protected, right? So I mean, I'm face to face with COVID-19 patients all day, you know, wearing my N95 and face shield and all this stuff. But I also have to be in meetings with other doctors who are also face to face. And I get these emails all the time. You have been identified as having been exposed, and then I run off and freak out and blah blah blah. But I keep myself in basically complete quarantine besides work. So there are only two places. It's been like a month or something when we really started having a surge here, but I go to the hospital and I come home. My groceries get delivered via app, but they leave them outside the door. I don't interact with people really at all. And that's actually because my greatest fear is that I will infect somebody, that I will get infected, not that I will have a bad outcome. I'm pretty healthy and young, but that I will infect somebody like my mom or my dad or my grandmother. And I won't do that. So I mean, I haven't seen my grandmother in months and months, and my mom and dad in like 6 weeks, and even then we're staying far apart, and it's tough. So I'm looking forward to the vaccine as the ability for me to say, okay, I've taken a big step forward in terms of making sure I'm not going to make them sick, and then hopefully they're going to get it, and then, you know, I'm going to be able to get back to normal life. So that's why I'm going to get it now. Yeah, if I had been infected, I probably feel a lot better after knowing that, like, now I'm way less likely to get infected again. Not guaranteed not to, but way less likely. We know that to be the case.
Yeah, it's extremely unlikely to get reinfected.
Right.
Another thing, just to bear in mind, we know what was it, 17 million people now in the United States with confirmed COVID positive tests, I believe. And the CDC even says that between the asymptomatic people who never got tested and just the people who thought, you know, they had a cold and didn't tell anybody and toughed it out, it turns out they probably have COVID, there could be as many as 8 to 10 times as many people in this country who have already had it, which could mean that we're close to like 40% of the population may have been exposed or may have had COVID. So even though, and by the way, nobody knows what percentage has to develop immunity to reach herd immunity. It depends on the virus. It depends on its replication rate, et cetera. But generally speaking, most people who deal with this thing, 60 to 70% of the population would need to get immunity for us to have herd immunity, so that the people who haven't gotten the infection and haven't gotten vaccinated could, in a way, kind of free ride off of the other people, because those people are presenting roadblocks to the transmission of the virus. So when you add the people who've already had it, plus the people we think have already had it, then we really don't need for everybody. If there are people out there who are really honestly afraid of getting vaccinated, we probably don't need them. We probably need maybe another 30 to 40% of the population to get vaccinated, and then plus the people who already had it, I think we'll probably be safe. What do you think about that?
I think you're probably about right with that estimate, but that's, I mean, we just won't know until it happens.
Right, of course.
Yeah, biology is complex.
Yeah.
Kyle, we've got a question for you, Kyle, actually.
Okay.
Oh, did you want to say something more?
Well, I was gonna say I had a private question, but maybe you have access to it and that's it.
Yes, it is. It is. It's yours. If you've read it, go ahead and answer. Well, let's read it. Let's read it, everybody.
Okay. You want me to read it?
Either way, the question is, you said Venezuela might get away with only about 35 COVID victims, but given the state of their existing healthcare system, how would you know? We assume 37 is the marginal increase due to COVID, but what is that on top of the millions due to common flu and ordinary sepsis, etc.?
Okay, I didn't say that about Venezuela. I said that about New Zealand. I'm sorry. If I said Venezuela, I'm sorry. That's a habit. That word comes out of my mouth all the time. But I meant New Zealand. No, Venezuela, nobody has accurate statistics, but Venezuela has had, based on what I've heard from people on the ground, widespread deaths. They've had hunger deaths. Things have broken down terribly. It's a disaster over there, but nobody really knows the scope because there's no reliable statistics. New Zealand right now sits at about 25 deaths. And so with the vaccine coming, there's going to be an upper limit on those deaths, and it's definitely probably going to be in the single digits. So yeah, you're right though about, okay, so any country, right, whether it's Sweden, the US, New Zealand, all of which have distinct COVID-19 policies, you can't judge them solely by the COVID-19 deaths. You should be judging them on all-cause mortality and how that deviates from expected all-cause mortality over the course of the pandemic, because all-cause mortality is higher, at least in the US, than COVID deaths. I don't know what it is in New Zealand. And the reality is these statistics take time to compile. So it'll probably be a year before we really have reliable statistics across a wide range of countries with a wide variety of policies. And then we can look at the difference in policies and the difference in all-cause mortality, which is going to take into account things like delayed cancer diagnoses, like deaths of despair and suicides from that. And we can then kind of get a good picture of the overall human cost. And we'll also have the economic costs, which we can use as kind of data that helps us compare. So that's, I mean, it's just, what I say is a lot of these questions that we argue about what is better as kind of this as far as what policy is going to lead to fewer people dying, what policy is going to lead to less economic devastation. These are empirical. We can prove these empirically after this is all over. We'll be able to answer that without question. And I'd like to see that people this country is a horrible policy. Okay, I wish you would put a bet on that and make it nice and public so we can come back when the data's in and we can evaluate how you did as a predictor.
But bear in mind that your earlier examples, New Zealand, Iceland, and Cayman Islands. So New Zealand is an isolated island nation with a population of 4 million people. In fact, it was the last part of Earth to get inhabited by humans. It was something around the 13 or 1400s is when Polynesians landed there because it's so remote. And then you got Iceland, is about 300,000 island people. And then you got the Cayman Islands, which I don't know the population there, but I got to imagine it's less than Iceland. So, you're not making apples to apples comparisons.
Agreed. We're and we're going to have a lot of interesting scientific and economic and public policy debates that I think are going to be much richer debates if we have them when this is over. And that's just because the data is going to be there for us to make objective assessments of how these policies worked out. And, predictions are very cheap. I remember, what was this guy's name? Epstein or something like that, who predicted there would be 500 deaths in the United States. And now he doesn't post on Twitter anymore.
Yeah.
From the Heritage Foundation.
And another thing we'll need to do when we do our I hate to say postmortems because that's probably not a good word to use in this context, but when we retrospectively look at this whole picture, we need to consider not just deaths directly related to COVID. We have to figure out a way, that may be hard to figure out, how many deaths were attributable to the restrictions for COVID.
Yeah, well,
why those are long-term and not readily visible.
right? That's where you look at all-cause mortality versus predicted all-cause mortality. And, there'll be debate about what percentage of that was unidentified COVID versus deaths of despair, but we should be able to look, further into causes of death, and we should be able to get a pretty good idea.
Yeah, because
The uptick of alcohol-related deaths is probably related to COVID-19 restriction.
there's already evidence that drug overdoses are going up more rapidly than the trend line. And we'll have to see what happens to cancer mortality, because there's a lot of delays in diagnosis.
I got a private question real quick, because I thought this was the one, but it was from Walter Smith, and he said, mRNA vaccines seem like a new technology. How can you be sure of long-term safety? Mm-hmm. I think that's a really important topic for us to address. Jeff, do you want to answer that first, or you want me to?
Well, let me, you embellish on what I say. Basically, with any vaccine, you're going to have to follow these long term. Right now, everything looks great, but just like with any drug we develop, sometimes things look great even after 10 years of trials. And then there've been times when it took the FDA 10 or 12 years to approve a drug, and then a few years later they recall it. So you learn things as you go, and the companies are going to continue to monitor the results. That's number one. Number two, based upon the way in which it works, it's kind of hard to imagine significant long-term problems. For example, the mRNA degrades after a matter of a day or two. It degrades within the cell. That's what mRNA does in any cell. So it's not even like this could linger around your system and cause problems for you. But that's my answer. Go ahead, Kyle. Tell me what you think.
My answer is that there's always an unknown. And let's be fair, it's a relatively large one here. And we're rolling out a vaccine to literally billions of people. And so there will be things that come up that we didn't expect. I mean, you just can't give a vaccine to billions of people and expect that you just know everything that's going to happen based on a 30,000 or 40,000 person study. Now you have to ask yourself, how likely is that? And what are the unknown? And what are the alternatives? Because COVID-19, we're finding out, as unknown unknowns too. We have post-COVID-19 syndrome, where people are having these chronic pain, neuropathies. We have COVID-19 associated cardiomyopathy. I've seen a few of these cases with heart failure, even in young people who didn't even have very severe disease, but we're identifying that. COVID-19 can cause things like Guillain-Barré syndrome and other autoimmune illnesses. So you're weighing it against that. All right, you're weighing massive vaccination and the unknown against the problems that we're going to have from COVID-19 that are going to crop up similarly. So I don't think there's any reason to believe that we're likely to see, because we don't usually see, either from viral infection, bacterial infection, or vaccination, side effects show up years down the road and get linked back to that. We see them show up in months to maybe 1 year on the outside. So, we're getting close to that. And then I would say that there's a hidden advantage in the way they're doing the rollout. Because for me, I should be willing to accept the higher level of uncertainty because I'm so likely to get infected. If you're 90, you should be willing to accept the higher risk of uncertainty because you're so much more likely to die or have a bad course of disease. If you're 20 with a normal BMI and no medical problems, you should accept a way lower level of uncertainty before you got vaccinated. And so the nice thing is that the highest risk people are going first. And it's going to be months and months. And that means months and months of additional data until we start getting into people who should really be accepting lower levels of uncertainty. And at that time, there will be lower levels of uncertainty. And so I think that's kind of a very beautiful side effect, is that the people who should be getting a vaccine early and taking higher risk are doing so, and the people who shouldn't aren't.
I would be remiss as a libertarian not to mention at this point that this is assuming, of course, the government has purchased the vaccines and is distributing the vaccines.
Right.
For those who are not familiar with this, I recommend you go to John Cochran, who's a Stanford University economist and is an adjunct scholar at the Cato Institute, wrote a really fascinating blog post probably about a week ago. It's under the Grumpy Economist. You should be able to find it, where he points out in a purely free market situation, and it's just something to think about. It would go to the people who offers the highest price. And the people who are willing to pay the highest price are the people who have the most to lose. So in a way, instead of the government deciding who gets it, the person who stands the most to lose by getting COVID is going to be the one willing to pay the higher price. It's just a really interesting analysis that I think every one of us should read.
Yeah.
But in the real world, we're dealing with the government has purchased and is distributing the vaccine.
Exactly. They've purchased it, they're distributing it, and nothing I say or do changes that. I don't, so as somebody who really believes in prices as a mechanism for distributing goods and services, and believes in free markets, right? It's attractive to say, well, maybe the government should just sell this to the highest bidder. But I have a few problems with that. And the first problem with that is that high prices that result from a scarce good being sold to the highest bidder benefit everybody because they serve as impetus to the manufacturers to make more. The government's already basically said, like, we're going to buy everything from everybody who can make this vaccine, right? The demand is just like to a limit where additional demand, it's not like if they could sell the first 1 million doses at $100,000 a dose, that they're going to produce more and faster. So we lose that benefit. And then the second thing I would say, sorry for this argument, but a significant portion of our population, of the most vulnerable people, don't have any money at all. They are people who are destitute in nursing homes, and they're the ones taking up most of or a large portion of the hospital beds. If we want to get on top of hospital capacity, we have to protect those people. And the idea that it's most valuable to them, but they do not have economic power. I would happily write a $100,000 check today to get myself and my family vaccinated. Happily write it, but I can't. And the reality is that there are people out there who need it more than us, who don't have any money at all. And I hate to make this argument. And in a free market where you have those high prices initially provoking rapid and increased production, this makes sense. There's a social benefit to me writing that big check. It produces so much more on the back end for everybody else. But when the government's already come in and bought up everything, if they're then going to say we're going to sell to the highest bidder, to me, that's just a bonanza for the government. That's just
No, I didn't say the government would sell to that. I said the pharmaceutical company would sell to that.
Okay. So there was
the
a
government. The government's
about
buying it all up right now.
Yeah, so
that takes the that takes the normal market forces out of the equation.
Right.
But Cochrane is saying, in an ideal world, Pfizer and Moderna would sell to the highest bidder. And,
I completely agree with that. I completely agree with that. I misunderstood Cochrane because I understood him to be arguing that the government should be selling to the highest bidder.
No.
And that I was like, well, no. But if he's not arguing that, I'm sorry for misrepresenting.
In fact, he argues that we probably wouldn't have had a recession either, because the people who stood the most to lose are usually people who are firing up, who are the engines of the economy, so they pay for it. That would stimulate more production. They'd be back at work sooner. And it's a really interesting blog post. I just recommend. It's too complicated for here today, but go to the Grumpy Economist and you'll find it. And I recommend it.
Okay.
We've got one more question, and I think this probably, given the time, is going to be the last question. It's from Glenn. I read an article which argues that since the vaccine was developed early last spring, it should have been made available immediately for real life testing by volunteers. The desired goal could have been achieved much sooner and saved thousands of lives. Could you comment on this? I'm going to start just saying that just because the laboratory work is done and the first clinical studies are started, there are requirements that the FDA has put on human studies. And so, and also, of course, FDA had to give the emergency use authorization for this to be sold. So, there's regulatory requirements that do go into that. And Kyle and Jeffrey might want to comment on that more, or they may have something very different to say.
I agree there are regulatory requirements. I don't think there should be. I think Glenn makes a really good point. I think ideally the drug companies should be able to deal directly with volunteer patients. And they also want to be ethical, and they have liability concerns. So everything would be out in the open, and we can get this much faster. I think I think if the FDA wanted to as separately, parallel, run its own trials, I recommend there is a great opportunity for me to plug my work. You may see it behind me, Drug Reformation. Michael Cannon and I wrote this white paper for Cato. It came out about 2 months ago. And we get into the whole issue of the FDA controlling and requiring prescriptions and controlling, infringing on our right to self-medicate. So ideally, I think Glenn makes a very good point.
I think Glenn makes a good point as well. I guess I would say that we have to understand that to some extent, some of the regulation overlaps with reality. And what I mean by that is that Moderna had very early done the lab work, and yeah, you have to go through the FDA approvals. But you also really do have to test drugs before you start selling them. You can't just whip something up in the lab and then sell it, because nobody will buy it if they don't have evidence that it works. Nobody will buy it if they don't have evidence that it's safe. And you have to go through a process of figuring out what dose to give it in. That's the phase 1 trial. So what I would suggest is that the appropriate amount of studying the drug should be determined in free market-based process, and not by a centralized planner. And I would say the one thing we could have done to make it faster would have been to conduct challenge trials. And we could have probably shaved 4 or 5 months off if we would have been willing to conduct challenge trials. And what that means is that you take a bunch of people who are low risk of bad outcomes, you inoculate them, and then you purposely expose them under controlled conditions to the virus, and you see how they react. And you probably also have to expose a control group who were not inoculated. But with a challenge trial, you could have been done in 3 weeks with proving efficacy. And then you could have immediately started this kind of experimental marketing where you're marketing a drug saying, we don't have all the data about safety, but if you want to buy it now and get it now and enroll in monitoring, we're going to start looking at at this and selling it and publishing. So you could have seen, a substantial increase or in speed of rollout if you had allowed challenge trials and allowed earlier marketing, but not probably as quick as some people think. It wouldn't have happened within 2 weeks of developing the vaccine.
Yes. Okay, well, I think we have to wrap up now. So I'm just going to say a few words, and then if our panelists would like to make some conclusions on their own. And my few words basically are, I hope that one of the things that all our listeners have gotten from this is a complex subject. We don't have all the information yet. And so, of course, this makes choice, whether you should get the vaccine or not, maybe a little more difficult than you would like. And unfortunately, that's life. And that's, of course, why as libertarians, we believe that choice should be yours, your body, your choice. And I'll ask our panelists to say a few words if they'd like, and let people know how to get in touch with you. Because, after this, they may be watching this again and thinking, oh, I'd like to ask this question. And we actually do have another question from Kristen that I'll send to both of you. And if you care to go ahead and answer that would be great, or I can do that. But for those of you who want to get in touch with me, the best way is to go to my website, ruwart.com, go to the About tab. It'll show you how to contact me. The reason I recommend that, I get a special flag on those, which means that you won't get put into the spam folder, and I'll be able to see your question right away. So Jeffrey and Kyle, why don't you say a few words and let people know how to get in touch with you in case they want to ask you more questions.
Okay, well, I could be reached at the Cato Institute website. It's cato.org. I have my own page. If you click under experts, you'll see the experts listed in alphabetical order. You can click on my page, and all my work, articles, papers, whatever, are available for you to see there. I could also be emailed at jsinger@cato.org, and I'm on Twitter. My Twitter handle is @DR4Liberty. That's Dr. 4 Liberty, DR 4 Liberty. So that's how you can get a hold of me. I got to echo Mary's remarks. I think I personally am very excited about the vaccine, and I'm getting vaccinated, and I would encourage people to do so. But I also respect people's rights not to do so. And I think that when this thing is all over with, there's a lot we can learn that is an argument for libertarianism and for liberty. because it's the regulatory apparatus that has largely stood in the way of a more nimble response to this pandemic.
Well, to get a hold of me, Twitter is @KBVMD. My initials, Kyle B. Varner, KBVMD. Or KyleVarner@gmail.com is my email address. So I would welcome anybody to tweet or to email me. I guess I would say, I'm going to get the vaccine, hopefully in the next few days. That we're still working on the appointments. My hospital is 12 or 24 hours behind Jeff's hospital, but I'll get it as soon as I can. I would crawl over broken glass and write $100,000 check if that's what I had to do to get it. I see the worst outcomes of this disease on a daily
Hey, maybe
basis.
I'll sell you my position in line for $100,000. That sounds like a good price.
But anyway, this disease, and I see it in the worst forms, is a global scale tragedy that's never happened in my lifetime, and I hope it never happens again. But the real story of triumph here is going to be how science, for the first time in human history, just put an end to a pandemic before it ran its course. And that's something that is amazing. So I would urge everybody, obviously it's your choice. We have to respect each other's freedom to get the vaccine, but I would urge the vast majority of people to do so as a way to protect yourself, but also as a way to protect the world, and also as a way to protect your freedom, because having the pandemic takes away a pretext that autocrats are using and central planners are using to infringe on freedom. So I think there's a lot of good reasons to take the vaccine. And I would just end by saying that the most important thing that anybody can do in this situation is to recognize reality. Reality that is not subjective, and it doesn't depend on whether that supports my narrative or my political cause. Reality is reality. And we're in a bad situation as a world, and we have to take responsibility as individuals. I'm not talking about government action. I'm talking about individuals behaving responsibly to protect ourselves, our families, and our communities. And if we do that, we're going to get through this.
Great. Well, I want to thank both of our panelists. This has been a wonderful discussion. I know I'm starting to get a little bit more questions and things coming in. I will send them all to you. And of course, if I feel like I can contribute to the discussion, I will. But I want to thank you again, both of you, for taking so much of your time. And I also want to thank all of our attendees for joining us today. We really, really appreciate your questions. And as I said, if you have ones afterwards, you know how to get a hold of us. So have a great evening. And we'll be having more discussions of this type at Liberty International. And if you want to learn more about Liberty International, I hope you'll go to our website, liberty-intl.org. And we have a Facebook page as well. Join us there. Thank you.